integrating HealthTech into our current healthcare ecosystems. What does the future hold?
So, can I kindly ask you to introduce yourselves, please?
So, I'm Thomas Borges-Bartin. I'm a radiologist with a special diagnostic interest in neuroradiology and interventional radiology.
Good afternoon. I'm Jeffrey Dudley. I'm a noncoplastic breast surgeon based in the UK. I also have a research interest in perfusion assessment and AI.
Hello, my name is Chris Vassal. I'm a rheumatologist and I work at Malta Day.
Hi, I'm Sarah Rafalot-Sopardi. I'm a medical retina specialist. I'm an ophthalmologist and also work in Mater Dei.
Nice to meet you, a whole Mater Dei team here. I also work at Mater Dei Hospital. So, to start off, health tech is a very broad term. And it can actually imply medicines, the delivery of medicines, surgical innovation. To you, individually, what does health tech mean? And what has been your experience of working with this so far?
So, being a radiologist from a personal point of view, dealing with technology is a day-to-day. I take a lot of it for granted. I don't have as much experience as maybe some of the older clinicians, but for me, CT scans, MRIs have always been readily available. It's something which we take very for granted, and I think it's something which we'll continue to take for granted until we either lose it or we lose the skills associated with actually physically seeing a patient or needing to do something ourselves, and we don't find that extra push from technology.
Jeffrey?
It's a very broad subject, and I think we currently associate tech with digitalization, IT, and computers. But I think any application of science to improve the patient journey at any level, even from an administrative point of view, is health tech. Now, our current perception of health tech nowadays is computers. But as Thomas said, there are other applications of health tech, the use of radiation, any chemical tests and whatnot. So I think it's a very broad term from a purely definition point of view. From a patient's point of view, I think they see tech as anything which is a machine, equipment, and anything which helps us, improve our care.
Dr. Vassallo?
As a medic, obviously, I tend to treat my patients with medicines. So, like everyone on this panel, I don't really operate. I don't know if Thomas, I can regard you as a surgeon, so to speak.
He's an interventional radiologist, yeah. So yeah, gets his hands dirty.
So I'm a rheumatologist. I treat patients who have bone disease and arthritis more than anything. If you had to look at the medicines that we use, they have been completely revolutionized over, I would say, more or less the last 20-25 years. The major probably advancement being the introduction of biological treatment, which is targeted therapy for specific cytokines usually, or interleukins, whatever you're targeting. And these have come around thanks to the advances in technology, essentially. So if you had to look at a patient with rheumatoid arthritis, you Google it, you'll see all these nasty pictures of hands and fingers all deformed. You don't see patients like that anymore. The few that you do see are the people who were diagnosed decades ago, and essentially they were born too early. So in my field, the most advances came from that. I can spend longer speaking about imaging, etc., but that is probably the biggest way how our specialty has moved forward.
Dr. Refalo?
On my end, I think in ophthalmology, I like to consider health tech as an adjunct, not a replacement. I'm aware, obviously, that like everyone else, I much prefer to have the certainty of an imaging technique. But on the other hand, it cannot completely replace our clinical experience. And the reason I'm saying this is to jump on what Thomas said. If we don't have the technology with us, what are we going to do? And as an ophthalmologist, I do come across this in clinics where I don't have all the imaging equipment I would like to have. I solely depend on my clinical experience. So it's a fantastic adjunct, but it cannot simply replace what we learn throughout our training.
So I think we can all agree that we do a pretty good job in taking care of our patients, and we're not trying to reinvent the wheel or do something that's incredibly different, but what we're trying to do over here is trying to do it better. And AI and digital health is actually giving us the tools to actually improve our service and the way we are treating and operating on our patients. So we're very lucky to have a very mixed panel with a lot of different subspecialties. Mr. Dalli, you've done some incredible research in the field of fluorescence-guided surgery, and this ties very nicely with precision surgery. Can you tell us more about that, please?
Yes, as per my presentation, my research focuses on perfusion assessment, so assessing circulation, and we assess that using near-infrared, so outside the visual spectrum, and we can see the blood perfusing the vessels because we use a dye which emits electrons which are picked up by the device. The technology component is that we are converting an analog image, something that is simply movement and change on a screen, into something quantifiable and objective metrics. That requires sensing, quantification, and then the next step, as I discussed, was artificial intelligence. So the application of tech here allows us to not only see things that are unseen by the eye, but also interpret them. And the final point, the key ingredient, is to apply a judgment. And that is where now the predictive medicine, machine learning, and artificial intelligence can help us as a surgical guidance tool in the greater realm of precision medicine as a whole.
So actually, AI can help us in our decision-making process. Dr. Borg-Barte, what has been your experience with this in using AI in radiology?
So AI as such hasn't really affected my day-to-day practice yet. What I am realizing is that there's a massive push for AI. It's kind of filling up that gap where there's a gap in basically healthcare workers to fill in that space. A lot of my colleagues do tend to poke fun at me that AI will take my job. I'm all for it. The less work I have to do in terms of sitting down at a desk reporting scans, and the more time I have to actually physically perform interventions on patients, that's all. I'm all for it. I mean, in terms of prostate imaging, up to 5 years ago, AI was considered inferior to an inexperienced reader. Now we're talking about AI being at the same equivalence of an expert radiologist. And all right, not an expert radiologist in the context of a multidisciplinary team meeting, but in the space of 5 years, it's essentially finished its training and gone above and beyond AI. So I think it's only a matter of time until, at least in terms of diagnostic scans, we are heavily aided, let's put it that way, and eventually replaced. I doubt it completely, but if it can reduce my workload, I'm all for it.
In fact, last year we've had talks about AI in radiology where we had reports of this actually being used as a screening method, and you would have actually a second screener who is a radiologist, an experienced radiologist, who sees the images after the AI. And like you said, if this can be used to help offload the clinician, you can focus on the more important tasks, such as the interventions. With regards to offloading, Dr. Ruffalo, you've used HealthTech very heavily in the pandemic and even post-pandemic to conduct your clinics and your checkups more efficiently. Can you tell us more about that and how that has helped you to actually improve your service?
Well, to be honest, we would have liked to be more efficient about what we have. At the moment, we have outreach clinics in the health centers and polyclinics where they do a great job in screening the patients. But then we have a massive problem because that information cannot actually reach us in the hospital. So the concept is brilliant. In the UK NHS, they have an excellent way to use this kind of technology. In Malta, despite it being so small, we have a massive problem in terms of the IT. So we cannot upload it on the systems, we cannot access it. So really and truly, although, as you said, we had to use this kind of imagery during COVID pandemic, and even now we're finding that it has a lot of, it's a brilliant way to reduce our clinical load in a way, because we can see much more patients in a shorter amount of time. We still have a lot of way to go locally, I'm afraid. So we're not quite yet. The radiologists are better at it so far.
I have some experience with telemedicine when I was in the UK. And I was, on getting there, I was there for 1 year, and I was quite surprised when I got there how a massive percentage of the work they do is via the telephone. They also were introducing Skype calls and doing consultations via Skype, which patients loved. And I was surprised by how many elderly people who you would imagine not being sort of tech savvy and computer savvy, and they would actually use, they were quite happy to get a lot of consultations done via Skype. They have the disadvantage of obviously greater distances, so patients loved it because it would mean that they wouldn't have to spend 2 hours getting to hospital, but in Malta we have traffic, so.
Yeah, but so HealthTech did actually help to improve the accessibility to the resources, despite the long distances.
And even though when the year passed, COVID sort of seemed to die down, because the impression I had at the time when I got there was, oh, we're doing everything over the phone because of COVID. But when COVID died, they kept doing them. They didn't say, okay, we'll switch back to everything face-to-face. They realized it works, and they were able to get more work done that way. So, unfortunately, there are no plans that I'm aware of for us to introduce something in my department, but it would be helpful, I'm sure of it.
You mentioned a very important subgroup of the population, elderly people. And while we are all for embracing AI and health technology, I believe that we have to be very cautious that we're not being biased towards a certain population and we're forgetting about the more vulnerable groups. What do we mean by vulnerable groups? People such as illiterate people, people who do not have digital literacy and who are not fluent in using technology, people who do not have the money and the access to such technologies. Most of us do possess smartphones, but especially people in third world countries will not possess these devices. Can we, in trying to make our healthcare system more accessible to all, can we be creating a bias and creating a gap in equity?
I think that's a very good point, Jessica, that we are now seeing rapid advancement in technology, but that obviously requires investment. And if we're going to switch to telemedicine, we expect the other party to have a computer, a smartphone, something of the sort. There also is another perspective, which is business continuity when these systems actually fail. So we have to be very, very careful, not only with regard to dependency on the systems, but also accessibility. As you say, those who are not digitally literate, those who don't have access to technology. I think we have to take a step back. We don't have to have a total approach that all our consultations are telemedicine. We don't have to switch totally digital, as in we can still have the forms we used to use 5-6 years ago available in clinic. But it's a matter of how best to use our resources. In most places in the developed world, healthcare is publicly funded, and every cent or euro or penny that we use is coming from taxpayer. It's a matter of cost effectiveness. So if I can switch 80% of my clinic to telemedicine and call on the patient's phone, I mean, we have to be honest, most people do have a smartphone, some form of smartphone nowadays. So you can have a web call with most of your patients. If at least you can diminish the load of our clinics or our consultations or even our interactions to, down to a small amount, that's going to be helpful. But yes, we do have to keep the ability to keep on treating people who don't have access to these technologies, don't have the abilities, either might have physical limitation, mental limitations, or education limitations to using this tech.
Basically, what we're doing is we are increasing the options for our patients. We're giving them the option of a teleconsultation, but we are also giving them the option to be seen in clinic, to have that patient to doctor, one-on-one human contact. And I believe that is very important, as Mr. Dalli has said, that we're not too overzealous in our transformation for digital health, and that we take a step back and we not forget the things that have always worked for us.
It's a bit of a double-edged sword as well. Probably AI can help us identify these patients which we actually need to physically see in clinic. This patient has defaulted twice. Maybe he should get a call before his next appointment because he's known to default, is known to present to emergency services inappropriately. I think AI will probably help not pinpoint, maybe personalized services more than change things a lot.
I can also jump in. I've had a lot of contact and experience because of the screening program with the elderly. And the feedback we're getting is that they much prefer this kind of system where it's not AI, in all fairness. However, they know that they're going to come in, it's 15 minutes, and they go back home. We have portable equipment, which makes it much more accessible for patients, even patients who perhaps have certain different abilities or patients who have different cognitive abilities. It is actually much easier because they don't come into a very busy outpatients. They're coming in, it's 15 minutes, they take the pictures, they don't need a long consultation, and they go home. And then we can safely contact them afterwards. So I do agree, we cannot completely exclude the percentage of the population who doesn't have a smartphone, who can't come in physically, but we can also combine the two things. So as you rightly said, we are increasing the options for the patients. So from my end, that's very good.
And when we talk about digital literacy, we cannot forget the workforce as well. It's not only the patients who need to be fluent with using these new systems, but also our healthcare workforce needs to be trained, and training needs time and it costs money. So if we look at the future, because the future is bright, what can we look forward to in terms of the integration of health tech in our healthcare systems?
I think, Jessica, there's two paradigms here. There's the research element and there's the clinical element. I mean, we're all clinicians, we're all patient-facing, and we have to sort of deal with the patients. But there's also the element, obviously, of us as researchers. I think as regards to research, it has become a lot easier to create new tools. And that is, we're going to see now over a very short period of time, a lot of AI tools coming on the market. The question then is, are they fit for use in a clinical environment? So we're seeing apps coming on our phone, but we're not really seeing now clinical tools that we're using hands-on in our clinics. The reason is it's going to take time until these tools are validated and proven. So what I suspect now is that we're going to have a lot of options, but we have to also be very, very careful that any new tool we implement, if it's patient-facing, especially decision-making, but even administrative, like identifying risk, has been properly tested and validated. And what we don't want now is to be using our patients as guinea pigs in something that is, essentially not validated. It hasn't met the standards that we would expect to achieve in other fields of medicine. For example, drugs, as in drugs will pass through a very long process before they're allowed to be used clinically. And we have to make sure that our new tools, which are available, have also gone through that process and aren't dangerous and harmful.
I think there's also the medical legal issue. Who's going to take responsibility ultimately? Because if we use the AI algorithm, and let's say it gets skewed, which is always a possibility, and you're very dependent on it, and the patient does not get referred, something is missed, who is going to take that responsibility? Is it the doctor? Is it the healthcare worker who's seen the patient? So there are a number of pitfalls, and I think it does need to be validated and tried and tested before we actually use it.
I'm all for pushing validation, but with validation, there's a lot of problems. I've met people who've been trying to develop artificial intelligence programs to kind of aid diagnosis. One of the biggest issues at the moment is legislation and actually getting a CE mark and all of that. It's a very laborious process, extremely expensive, besides the actual money of putting into research and development. So there has been an element of validation, which I agree with. We're all clinicians here. We all depend on evidence-based medicine, but we cannot stifle development as well at the same time. There has to be pathways for rapid integration of technologies which have been tried and tested through. But they also have to have easy access to the new, to real world circumstances.
I mean, you mentioned earlier in your field, Thomas, about AI sort of looking at the image and giving you a report. So we need to keep in mind that the AI is not 100%. Mistakes will be made, things will be missed. We briefly, someone mentioned legislation, not legislation, sorry, litigation, right? So who's responsible once the AI eventually? I think it's a matter of when that program doesn't pick up what it's meant to pick up. I mean, the systems need to be implemented before in the eventuality that this might sort of occur. I'm not very well aware about AI in radiology. I'm not going to lie, but it is something I've often thought about. That if it's 99% accurate, that 1%, you can argue that no radiologist is 100% neither. A radiologist might be 97%, but at least and then he can sort of shoulder responsibility, so to speak.
It's a double-edged sword. And breast screening is being used in the UK a lot. If two radiologists are 99% accurate, but an AI is 99.98 accurate, in that 0.9 case of patients who are missed, who shoulders the responsibility? Because the technology is not implemented.
That's another valid point. Yes.
I think there are valid arguments, but I think we're missing the main point is improving patient care. I mean, there has to be a change in legislation, and that is going to have to be clear because a radiologist is not a person, an AI tool is not a person, and there obviously every tool is going to fail. But the question is what opportunities is giving us, and also is it going to be a replacement or an adjunct? So one of the biggest tools currently on the market to do with surgery is the GI Genius, where when you do colonoscopy would kind of highlight the area, tell you, listen, there might be a polyp there, look there. It's not taking a decision, but it's supporting you to focus a bit more. And I think that kind of bridges the gap that, yes, maybe we should not be totally leaning on the AI, but maybe using it to support us. Clearly, from the research I've done with patients sort of interaction, the patient will expect the surgeon, the doctor, the physician to take responsibility and explain the outcome. So the onus is most likely going to remain on us. Even if the AI succeeds or fails, we have to face the patient, explain to them why, how, or when. And that then goes to the step is how has the AI been trained? Bias and generalizability to the population. Has the AI been trained, for a population that we're using, and the circumstances that we're using? AI trained in a big center in the US is not necessarily useful for us in a clinic, in a peripheral clinic somewhere else in the world.
I believe we've highlighted both the benefits and also the disadvantages of digital health and of integrating AI into our daily workforce. And I do agree with Mr. Dalli. This is not a replacement of, so HealthTech is not replacing the clinicians, but is rather a tool which is helping the clinicians to do a better job. And I believe at the end of the day, the responsibility is still with the clinician. We are responsible for the patients. And these new technologies are not being developed to take away from our responsibility, but rather to help us make better decisions, keeping the patient at the heart of it all. Do we have any questions from the audience? Okay. So one last question from me then. If you had to make one recommendation, what would that be for the people who are actually the stakeholders, the ones who make legislations? We have some people in the audience as well who are high up in the Mater Dei Hospital hierarchy, who are involved in these policies and decision-making. People from the government who are here today. We've had the health minister as well. So if you had to make one recommendation, what would that be?
Keep your employees happy because they're the ones who are doing the work at the moment.
From my end, I think we mentioned that there is a human element to development of these tools. And we're talking about AI, but we still have not fully digitalized our process in healthcare. There's a lot of digitalization that has to happen. This is a process and it's going to involve breaking down certain barriers and certain ideas of what a clinic should be, of what a consultation should be. Can we have a telemedicine consultation? Do we need to examine a patient anymore? So my advice is to start to engage in this process and see kind of long term. So help us digitalize and develop the data so that the AI can then work on this data, both from a research point of view and from a clinical point of view.
So My recommendation would be to the pharmacists who are in the audience, please help me get more medicines for my patients. That's what I would like.
I think that's very fair, to be honest. From my end, my suggestion or my hope is that we can amalgamate the current systems. There's a big divide between primary and tertiary healthcare. We cannot access their systems, they cannot access our systems, and I would love for everything to be under one system and just healthcare.
Thank you all. Some very valid recommendations there. It's been a big pleasure having you all here, and I wish you all a pleasant afternoon. Thank you very much.